want to welcome Dr. Make sure I get it right, Cami Winkelspecht.
You got it, Winkelspecht.
Yes,
yeah.
Winkelspecht. Okay, so welcome. We're thrilled to have you
Absolutely.
here, and I know she's going to have some time afterwards to answer some questions. So the floor is yours.
All right, sounds good. Thank you.
Thank you.
Welcome, guys. Good evening. Thanks for coming. I know that the topic doesn't sound that uplifting, right, as you think about like a Monday evening, but hopefully the goal tonight is to do some good education and learn a few things, and then hopefully kind of instill hope in the situation. So I always say that when I work with families, that the goal is to help you understand kind of what evidence-based care is, what those options are, and kind of get excited about life again. So hopefully we can think about some of those tools and tips and tricks. I do like to move around, if that's okay, so I'll probably move around. Please don't hesitate to stop me and ask questions if questions come up through there. I'm not married to the you have to wait until 7 o'clock format for Q&A, especially with a group this small. I would rather you just stop me and ask a question then. We can all probably learn from that experience, and so just let me know if you guys have questions. Sound good?
Yes.
Awesome. Okay. Some material, as I highlighted in the beginning here, is from the American Foundation for Suicide Prevention. I always like to highlight this as a resource. So they have tons of resources on their website that are actually ready-made presentations that you would give to church groups, that you would give to schools, that you would give to daycare centers, all types of different age groups. So from younger kids to older teenagers and also adults. And so they want people to have access to the information. And so I'm going to show you a snapshot of kind of what they have organized too, because I think it's a really nice resource to continue learning, but to think about. Nope, I got it right. I'm glad I remembered the down button.
Yes.
Yes. So our agenda for today. So knowing the facts, so we're going to do a little bit of sorting out facts versus myths, which I think is really important when we think about depression and suicide prevention. There are a lot of myths that I think prevent kids from getting care, adults from getting care, and then parents and teachers and adults from asking kids about these symptoms. And so we'll talk about a few of those things to kind of orient us to the topic. What do we know about childhood depression? So some statistics, and then talking about the symptoms, and then what does effective treatment look like? So one of my favorite things about my job is being able to work with families to really provide good education about what should effective treatment look like. I think sometimes when you enter kind of a behavioral health context or seeking mental health treatment, it feels like you're just looking to the expert to kind of figure out what to do. And I think parents are really good. We should do a lot more kind of direct-to-consumer marketing, so to speak, about what is good treatment, right? What should it look like? What should we be asking for? What do we know about the literature? And helping equip parents and teachers to ask those questions to make sure that you're getting what you need and not in treatment for a longer period of time with something that's not necessarily working. So we'll talk a little bit about what that looks like. Then we'll switch focus a little bit to think about suicide prevention more specifically. So focusing on, again, at the fact that everybody can make a difference and simple ways to really help and create an impact. Because one person we know can make a huge difference and possibly save a life. And then we'll do a little wrap up and Q&A. But again, you guys can stop me as we go along and let me know if you have questions. Just a quick disclaimer, so the goal for today is not for me to do kind of diagnostic, right, assessment or kind of clarification, so it's to really help us think through education. So specific diagnosis and treatment recommendations and those types of things would have to be done in kind of a more formal mental health context and assessment. If you're looking for good resources in general for kind of the Delaware area and the closer two counties of Pennsylvania, we actually have a really great resource that we worked to develop as a team last year. At nemours.org/kidscope, and it goes over all of, it has fact sheets, it has a lot of information, but also links to local resources and organizations that we've worked with to try and build relationships with for the community so that you can access care more quickly. The other tier resources are about child therapy and kind of treatment, and so good resources to help orient you to what does effective treatment look like, what should I be thinking about. There are really nice guides that say, here are 5 questions that I would ask my therapist, or here are 5 questions that I would ask my pediatrician to really help make that information accessible. All right, you ready? So I'm going to ask you guys to participate, right? There's no right or wrong answer, right? No judgment necessarily. So the goal of doing this is to just kind of open your eyes to what are some of the myths and facts that are probably out there. And the ones that I picked for the list, I think, are some of the ones that actually prevent seeking treatment the most or kind of lead to some misconceptions. So let's think. What's the first one? One primary symptom of depression in children and teens is irritability. Fact or myth? Being irritable. that edgy, walking on eggshells, kind of like yucky, angry? What do you think? Myth or fact? Fact? Fact. So irritability is one of the primary symptom differences between adults and children. And if we think about that, actually the symptom criteria are different. So instead of actually having kind of like sad, tearful mood for most of the day, every day for 2 weeks, for children it can be replaced with irritability. And if we think about that, I actually think the reason is very logical. So if I was an adult and I was facing depression, then I would potentially be able to choose to get out of bed, to do kind of day-to-day activities like homework or brush my teeth, like those types of things, right? And if somebody didn't make me do those, I could choose not to do them. I think for kids, you don't really have that option, right? So if you're feeling kind of depressed and you're feeling yucky and your mood is off, we're still going to make you get up and go to school and brush your teeth and all those other things. So it makes sense that I would be a little bit irritable and a little bit angry about that. So I think oftentimes we see depression kind of masked as behavioral challenges, and you see it come out in that anger, irritability, and arguing. So I think this is a really important one for us to think about. All right, myth or fact? If someone wants to kill him or herself, nothing can be done. Like they've made up their mind. Myth, good. So we know that one person asking to help and asking how they're doing can make a huge difference, and the research is pretty clear about that. All right, myth or fact? Teens will reach out to peers or a trusted adult and share signs of depression and thoughts of suicide if those adults or peers show that they're willing to listen. Fact. Yeah, it's not easy to talk about depression or suicidal thoughts, but we know that actually kids and teenagers will do it if we start the conversation. I think oftentimes when I'm working with families and we're asking these questions in kind of an initial intake, I do think people were surprised about how much children will share, but they're usually pretty direct. And again, the amount of information that kids I think have about depression and suicide and what is suicide, I think that age goes down a lot, right? Where we're seeing kids who are a lot younger even than 10 or 12 who are coming in and having kind of had suicidal thoughts and or made kind of gestures, just because I think it's something that people think about a lot more now than they used to. And we're also asking about it, and so we're identifying it, I think, earlier and a lot better than we would have in the past. You must have a reason to be depressed, right? Something had to be wrong. There had to be some kind of identified cause or trigger or something bad happened. Myth. So depression can happen to anyone and be the result of biological, stress, or other environmental factors. So it could be likely a combination of all of those things that might lead to kind of the backstory of depression, and so there's oftentimes not a single trigger. I actually think that's what's very frustrating about it sometimes when I'm starting to kind of work with families and kids, is that I think you're really looking to figure out where things went wrong, and sometimes it's not that there's a single thing or this time period that was really stressful, that it kind of changes and you have these behavior patterns that emerge over time, right, and kind of worsen. So there's not always something that we can find that's kind of the one cause. Asking someone whether they're having thoughts of killing themselves gives them the idea. This is a big one, right? You guys are laughing, right? So you're thinking, what? This is a myth, right? But you would be really surprised at how often I give this presentation and I get that question every single time. Because I think it's really scary to actually talk about that and ask the question, even as providers. So I do a lot of training and education for students, and we practice asking these questions over and over and over again, because it's even challenging sometimes for mental health professionals to feel comfortable asking about all of these thoughts and kind of responding, just because it's tough, right? It's really hard when somebody kind of shares that information and you think about kind of what to do. But we know for sure that asking them if they're having thoughts of killing themselves does not put the idea in their head. If anything, it does the opposite and gives us an opportunity to be helpful. So some quick facts on depression. At any given time, about 3.2% of children aged 3 to 17 have diagnosed depression. So that means that they have sought treatment and had a diagnosis. I say that because we don't know how many people actually might have depression and are not necessarily seeking treatment and might have that diagnosis. Rates of having been diagnosed with depression in children in this age range didn't really change from 2007 to 2012. The rates of depression have remained really steady. And I say that because I think we oftentimes read articles about whether kind of depression has been much worse and we're identifying it more in recent years, or whether anxiety disorders have been kind of more prevalent and we're stressing kids out. But at least for depression, we know that that hasn't necessarily changed over time, so those rates are pretty steady. 2 out of 3 children with depression don't receive treatment of any kind, so that's medication or therapy, which is a sad reality. Approximately 1 in 15 high school students report attempting suicide each year. More than you guys would have thought? Yeah. It's estimated that for every death by suicide, there are 100 to 200 attempts that either we're not capturing, not understanding, or are kind of going into this backstory of suicide. And it's the second leading cause of death for children 10 to 19 at this point. Yeah, pretty serious, right? So what does depression look like in children and teens? So affect can be flat, and we talked a little bit about how irritability can be part of this too. But oftentimes kids and teenagers are looking pretty like emotionless, right? So kind of a blank face, not necessarily having a lot of range of emotion, not really very happy, not really very sad necessarily, but just kind of there. Some kids actually describe it as meh, right? If you've kind of seen the emoji and you're thinking about the middle of a scale, like that meh feeling, is certainly what a lot of kids describe kind of in the early stages. Hopelessness, so not really feeling like anything is going to change, right? So every day is going to be tough. There's not necessarily something that's going to change over time. Tearfulness, so you can certainly see teary eyes. Eyes kind of welling up a little bit more, and I say that because it's not necessarily crying that happens all the time, but just kind of that on the verge of kind of tearfulness happens a lot. Irritable mood, again, that difference between children and adults. So when kids are really irritable and that's a change for them, then that might signal that something like depression is going on. Loss of interest in activities. So if kids were really interested in participating in like the track team, we're in basketball season, we're coming up on baseball, those types of things, or like art classes or music classes, and they're just, no, I don't want to sign up again, not really interested anymore, changes in what they would be kind of interested in doing. That can also look like social activities. So used to want to kind of hang out with some friends on the weekend are now really avoiding that and kind of staying in their room or staying home a little bit more often. Changes in eating habits or weight, so eating a lot or eating a little, right? Any of those changes could be characteristic of depression, or losing or gaining a lot of weight in a short time period. Difficulty sleeping, so this is a big one. Sleep is one of the differences that parents notice a lot more, a lot of restlessness, either kind of excessive sleeping, so coming home and taking naps after school. Pretty often now some high schoolers do that anyway, right? So I mean, napping I think becomes a thing in high school. There's that shift that happens in middle school where sleep becomes cool, right? It's not very cool for younger kids. I have a kindergartner and a 6th grader, and my kindergartner would never choose to go to sleep, but right, my 6th grader's starting to be more interested in that. So some of that's natural, but again, you would see a lot more of that type of behavior, either a lot of difficulty going to sleep, so an hour, 2 hours to kind of go to sleep at night, or going to bed at 8 or 9 p.m. and then waking up, hard to kind of wake up the next morning at 7 or so for school. Sometimes you'll see slowed kind of motor movement, so feeling like you're kind of trudging along a little bit, that you're kind of walking slowly, not necessarily, not a lot of pep in your step, so to speak, as you're moving around and kind of going through your day-to-day activities. And loss of energy or fatigue, just feeling really tired a lot, right? That I'm tired, I can't do that today. I'm tired, I can't do that today. That's something to think about. Negative thoughts about themselves. So this is something sometimes that parents do notice and sometimes not. So it's one of the more cognitive parts about depression, is what are they thinking in those situations that are kind of leading to these thoughts. It's part of effective treatment, just kind of figuring out what are those thoughts and how they're predicting their behaviors. But really having negative thoughts about themselves. I'm not a kid that people want to be friends with, nobody really likes me, I really am bad at school and that's not likely to change, those types of things. Inappropriate levels of guilt. What does that one mean? Any guesses about that one? This one's actually really tough, more related to actually kind of more significant depression. Any guesses?
It's all my fault.
Yeah, feeling a lot of responsibility in situations, right? Like I bumped into somebody in the hallway and I apologized 6 or 7 times because I'm really worried about what they're thinking about me and that I did something in that situation. It could have been a complete accident, right? It could have actually been the other person's fault, right? What if they left their backpack out and they were in your way? But somebody who's thinking kind of in a depression mindset is going to really think about that negatively as a reflection on themselves and hold a lot of guilt for situations like that. Difficulty concentrating. So it is a rule out, right, if we're thinking about the difference between kind of ADHD and anxiety. Difficulty concentrating is characteristic of all 3 of those things, so you kind of have to rule out depression and anxiety on your way to kind of making an ADHD diagnosis. Because certainly if you're distracted by thinking about all of these types of thoughts and kind of that sadness, it can really create an impact. Reoccurrent thoughts of death, suicidal ideation, or intent to complete suicide are certainly warning signs and symptoms. And then changes in routine and behavior. So you notice like kids aren't doing something that they used to do, right? They're having trouble getting out of bed and they're not remembering any good parts of their routine. Showering and hygiene, personal hygiene are things that parents also notice, so not caring about your physical appearance and being prepared and kind of ready for the day are things that parents would note more often, particularly in teenagers. Right, younger kids, you can still get them to kind of be forced to take a shower, but teenagers have a little bit more, right, it's called self-agency or like face value in that situation. It's really hard to get them to do that if they're not motivated. So what's typical mood versus something more? Because everybody feels sad sometimes, right? So everybody feels a little bit sad sometimes, and everybody goes through periods of time where they might be struggling with something. That's typical. So depression is really a pattern of behavior over time. And when we're thinking about it, we're really thinking about a 2-week time period. So things can shift mood-wise in a pretty short period of time. And so, right, somebody who had been doing okay, and then in a 2-week time period really displays a lot of those characteristics that we were talking about in symptoms, might have clinical depression at that point. So it can come on pretty quickly. And so if you think about if it can occur and kind of emerge in that 2-week time period, and then those symptoms persist, that it's often a long time before most people actually get treatment, so that they've been struggling with depression for quite some time before they come in for treatment. So you want to be thinking about, has this been going on for kind of more days than not for about 2 weeks, right? So not a bad day or a bad couple of days, but has this been kind of their general, mood, and that we've noticed these changes over several weeks? Are they preventing success at school, right? So what are teachers noticing? Are they seeing any changes in terms of raising your hand and engaging, or sitting with kids at lunch? Or feeling like they're completing tests and completing homework and those types of things. You see a lot of those things drop off if you're feeling really sad. Are symptoms resulting in changes in activities and interactions with peers? So again, are they just not engaging in things that they used to be doing pretty well or pretty excited about? Looking for those sleeping or eating patterns are big ones because you can directly observe those. They're not necessarily in the eye of the beholder, so to speak, for the child, but you can see that, like, wow, you haven't really eaten your lunch at all this week, right? I wonder why that might be, right, if you've not been hungry, or changes in sleep. Suicidal ideation, an expression of suicidal thoughts should always be taken seriously. So if anybody expresses those thoughts, I certainly want to understand what do we do about those, and to, again, respond quickly. So that's not something that I would wait to kind of figure out, is that serious, is it not necessarily serious? I would want to ask the question, and again, kind of be thinking about, is this related to something else? Any thoughts, questions about that? Okay. So I want to encourage you guys to really start the conversation. So often, again, it's really difficult to kind of notice these things over the course of a few days or a week. But as you're going into kind of week 2 and you're noticing some of these changes, I would certainly want you to kind of think about reaching out and gathering other information, right? For kids, thankfully, we actually have a lot of resources at our disposal, right? So teachers could talk with us, there might be coaches, there might be youth leaders at church or those types of things that could give us a lot of feedback about how kids are doing in all those different situations. For adults, it's kind of harder to get some of that report. So for kids, we have a lot of sources of information that help us to kind of understand what might be going on. Again, one behavior is not worrisome. One, sleepless night or 2 sleepless nights are not necessarily worrying me in and of themselves. It's that pattern that we're really looking for. So asking questions to see if your child or teen is able to chat. Do they want to talk about it, right? That you've noticed some of these kind of differences in the past couple of weeks and they don't really seem quite themselves. Would they like to talk about it? and just asking that question to kind of open up the dialogue. So has it happened before? Is it happening more recently? Would it be helpful to talk to somebody like a school counselor or a therapist about it? Kids, I think, are actually really good these days at kind of decreasing that mental health stigma. I think we know that we're kind of decreasing some of the stigma for mental health when kids are actually asking for treatment more. And so it's not uncommon for me to do an initial evaluation or an intake visit where kids are the one who are actually driving, bringing in treatment. We've done a good job, I think, of starting to kind of normalize that and seeking help when we need it. For teachers, I would certainly say talking about and gathering data with other people at school, right? Have other people noticed some of these changes, or is it just in a certain class, right, or grade-based or something like that? So making sure that you're getting that information so that you can give that to parents. I also wouldn't assume that parents know the information that you're seeing at school. Oftentimes behavior at school and home can look really differently because the expectations and the context are just really different, right? So I mean, like at school you're expected to do a lot of different things, you're around peers all the time, and we have a lot of different demands and expectations that are going on throughout the day. At home, right, we expect you to do some things, but not nearly that same kind of like density of information and intensity as a school environment. So it wouldn't surprise me that behavior is different. And so again, on either direction, I wouldn't assume for teachers that, right, parents are aware, or for parents that teachers are kind of aware without having that conversation. Treatment. So we know that treatment for depression, even though we know that 2 out of 3 people who are diagnosed with depression don't get treatment, we know that treatment is highly effective. So in as little as 8 to 12 sessions, you can make a big difference, even if you're an adult and your primary reason for coming into treatment is like suicidal thinking, right? We know that there are very specific evidence-based interventions that really help to change those symptoms in a pretty short period of time, which is great. So again, mild depression, so depression is categorized as either mild, moderate, severe. Mild depression is often very treatable with therapy alone. So if you haven't had a course of effective treatment or engaged in therapy, then it's often a really good place to start. For moderate to severe depression, so either that the number of symptoms that a child has is more significant or it's been going on for a longer period of time and accompanied with kind of suicidal thinking, those are the things that separate mild depression from kind of moderate to severe. Oftentimes a combination of therapy and medication are the most helpful option to be able to go in with kind of a 2-pronged approach to see if we can maximize the effectiveness. So what do we know? CBT is really effective. We're going to talk a little bit about what cognitive behavioral therapy is. Family involvement is crucial. I think this is a really important part. Again, we talked a little bit at the beginning that I think that parents are in a situation where you're kind of oftentimes looking for like the expert to kind of direct what should sessions look like. Should this be individual and about my child? My strong bias is to include everybody in that conversation as much as it makes sense to do that, right? So family members are a really important part of education. The reason is because I'm not going to be the person ultimately who's managing those day-to-day routines and when those thoughts kind of come up at home or when those thoughts come up at school, right? We can talk about strategies that are helpful, but I'm not going to be the person who's in the best position to kind of impact that day-to-day behavior. I also think that modeling transparency and talking about it is really important. It's not a secret, right? So depression is not a secret, suicidal thinking is not a secret, having a safety plan, right, or code word, none of those things should be secret. So we should all be really comfortable and work to kind of have that conversation and to talk about it openly. So parents and caregivers, again, I would include in almost all sessions with children and teens. Anybody familiar with CBT at all? This is the type of treatment that we know is the most effective for children and teens with depression and anxiety. It's actually the most effective for a lot of the childhood conditions as well as adult disorders as well. So some people are a little familiar with CBT? Yeah? Okay, so the goal of cognitive behavioral therapy is to think about how your thoughts, feelings, and behaviors are all connected together. So it's usually briefer treatment and focused on kind of solutions. So can we help kids to understand, which one of these do you think that kids and teenagers probably understand the most? Of thoughts or feelings or behaviors? Feelings. Yep, feelings are the easiest to identify, even younger kids, right? We talk about how to label emotion, and we do a good job, I think, of thinking about that overall. So usually our feelings are pretty accessible, and our behavior then kind of changes in response to our feelings. But kids are not usually able to identify the thinking part very readily. Sometimes you can see the behaviors, right? So you might see that, right, you're not interested in soccer anymore, or you're not raising your hand in class, but you're oftentimes not actually connecting that back to the feeling. What we know is true as well is that oftentimes there's a thought that's triggering all those changes in mood, right? So that a change in feeling and a change in behavior doesn't happen if you're not thinking something. It just doesn't. But until you get to about 8 to 10, you can't really think about your own thinking. This idea of kind of like metacognition, one of my favorite terms. It's so cool to actually see this emerge in kids, and I'm sure, right, as teachers and parents, you can think about this. The one day that you start to be able to kind of look back and take a perspective and see like, oh, I could do that a little bit different. Younger kids are just not able to do that. You could be the brightest kid ever, and it's really hard for you to take a perspective in a way that changes behavior. So most younger children with depression, that's really all aimed at actually parents. So parents using techniques to model successes, to think about success every day, to give them positive feedback, those types of things. So with older kids, you can then help them to be more aware of what their thoughts are in those situations. What are those negative thoughts that are triggered when, let's say, a friend kind of waves at you. Let's say I'm waving at a friend, or I'm waving at you, and you don't wave back at me. If I'm depressed, I'm probably feeling sad, right? And then I probably walk away. But I'm not very aware about what I'm thinking. What I'm thinking in that situation is, this person doesn't like me, right? And they don't want me to be their friend anymore. And if that's really what I'm thinking about at the end of the day, I feel pretty bad, right? So it leads to this feeling, and it leads to those behaviors. And over time, it just causes more social isolation, right, with this particular thought. If I really believe that in the situation, then I wouldn't be very likely the next day to wave at you again, right? Because, thank you for waving, I appreciate that. But I wouldn't be very likely to do that because it wasn't reinforced, right? Nobody responded, and I thought, oh, I'm just going to stop waving at people because nobody likes me anymore. So you can see pretty quickly that these thoughts kind of grow and get reinforced by changes in behavior and then lead to more of that sad feeling. So it's a real kind of vicious circle. So our goal is to kind of interrupt this circle, to help you understand it, and then to change some of the behaviors that you're doing to help you generate a different feeling and kind of replace some of those thoughts. So the goals of a CBT intervention are to really understand symptoms. So all cognitive behavioral therapy should start with thinking about your symptoms. So we should talk about them. We should know what are the symptoms of depression that you've had, how long have those been going on, what do we know about how depression changes how you're thinking, and what do we know about treatment. So a lot of good education goes into developing an effective treatment plan. So parents and kids have to both be on the same page about what they're kind of seeing, what they're looking at, and what the plan is going to be. And it's not a mystery. Understanding triggers, so when are these thoughts triggered, right? Like that situation where you're waving. That's a good one. That happens all the time, right? Where kids kind of misinterpret what's the goal or what's the other person thinking in that situation. So understanding that that particular situation for some kids would lead to a lot of negative thinking and a lot of like tearfulness and avoidance of those situations. So we want kids to really understand, kids and parents both, to understand what are those unique triggers. If it's a particular class, right, that they're not necessarily doing very well in, and those thoughts are really strong in that class, and that triggers suicidal thinking, we want to know that and help kids and parents and teachers feel empowered with solutions. We certainly want to increase use of active coping. So our goal is not necessarily to just get you to think about your thoughts. It actually doesn't help very much to think about how bad some of those thoughts are. We want you to do something different. So it's a pretty active intervention, right? So if you're attending treatment and you're not really getting a lot of active strategies, I would be unlikely to think that that's related to CBT, because we want you to do something and we want you to try something different, usually every week. Reducing negative thoughts. So we want to kind of reduce the likelihood that you're having the negative thoughts by getting you to do things that you're going to enjoy, and so to confront some of these thoughts. The goal is overall to kind of reduce and replace these thoughts with something that's a little bit more balanced. I think sometimes CBT and teenagers actually say this to me all the time. The goal is just to get me to be happy, or to think that everything is like super awesome. And it's like, not really, right? Because every day is not the best day, and it's not super awesome all the time, right? There are really like situations that are bad, right, each day, that are tough to deal with. But the goal is to have balance. Right, so the goal is not to just focus on the negative thoughts, but to also be able to take in and kind of process that positive information to give you a much more balanced look. So if I waved at you and you didn't wave back, I could think, what are some reasons that might be alternatives to, right, the fact that you don't like me and that you don't want to be my friend? What else could I generate? Maybe you didn't see me, right? Maybe you were a little upset, right, kind of like angry about something and weren't paying attention. There could be a lot of different ways to look at that situation. So we want to help kids to realize that there are different alternatives other than the one that they're kind of assuming. Reducing hurtful choices, so things like behavior and thoughts. That would be things like cutting or kind of like, right, non-suicidal self-injury, those types of things. We would want to reduce things like avoiding situations. We want you to approach a situation and to see what happens, right, to kind of try out an activity, or to call your friend or to text your friend that you haven't talked to, right, in a few weeks and see what they say, to start replacing some of those. Using exposures and to think about opportunities to practice. So exposure is one of those things that a lot of people kind of avoid. What we know though is that an exposure is really doing something different at its base. It's not necessarily really scary. We think about it for anxiety, right, and kind of forcing you to face your fears and something that's stressful. I think it's actually a big miss for a lot of clinicians thinking about depression, because how am I going to change that negative thought about my friends? I'm going to have to do something to test out whether that thought's true, right? So I'm going to have to text somebody, and oftentimes we'll actually do those things in session. We'll start to practice these things. Well, why don't you reach out to a friend now? Now? Sure. Why don't you do it now and see what they say? And 9 times out of 10, right, kids respond pretty quickly. Texting is a really good one, because everybody wants to text, and you see the ... that comes up almost immediately, right, that somebody is like listening, which is awesome. And so kids can generate that mood change pretty quickly from some of those things. So you want to design a lot of exposures that are going to help you to kind of target and confront those negative thoughts. Is this really true? Is that the only way to think about it? That's what we know good treatment for depression looks like. Thoughts or questions about that? About depression in general?
So, how can you tell something's effective? Can you give feedback, or recommend that, or just let the kids figure out it's working?
Yeah, that's a good question. So your question was, how do you know if treatment's working or if it's effective or not?
Especially talking about this work with the coping strategies.
Yeah. It's interesting. So I think you should see a behavior change, right? So like you saw a behavior change that led to the depression, kind of displaying itself over the course of several days or weeks, you should also see a change related to these positive behaviors. So you should see them trying to kind of do things a little bit differently, trying to engage more than they're trying to withdraw. You should see changes in mood, right? So you should see more kind of like smiling, a range of affect versus kind of sadness and flatness. Depression looks a little bit different for everybody. And so I think at the beginning and kind of throughout treatment, you really want to have a good conversation with your provider about what are the goals that we're really aiming for, right? What are we hoping to see first? When do we hope to see that change, right? I would oftentimes predict for families when I start working with them that I would expect to see a change if we were working on this weekly and we had the right treatment plan and it was working and we were all doing a pretty good job at that in 4 to 6 weeks you would start to see a change. And if we don't, then we should talk about what to do differently. As something's not working, right? Either the symptoms are more serious than we thought, right? So they're not changing. There's another barrier that we kind of haven't thought about, that might predict that. So sometimes anxiety is a part of that. Anxiety and depression are kind of like close cousins of one another. Most people who are depressed are also a little bit anxious. And if that's really where the source of the challenges are, like let's say social anxiety is what caused the depression, we have to think about that a little bit differently. But that should be pretty clear in about 4 to 6 weeks.
How about compulsions, like just like fighting or things like that? It's like,
Yeah.
it's a little different than depression.
So yes and no, right? So we oftentimes know that like non-suicidal, I'm going to use, instead of cutting, I'm going to use non-suicidal self-injury. It's like our fancy term because it could be things that are more than cutting, right? So we know kids actually do a variety of different things now, like burning, like you've got the eraser kind of situation that people were doing, red eraser burns that were happening. There are a lot of different ways that kids could hurt themselves. But you would see a difference in cutting behavior if that was one of the primary symptoms of depression. You should be focusing on that really closely, and you should start to see a change, right, in that same time period, 4 to 6 weeks. What I'm doing in that treatment is different, right, than what I might do with kind of general depression or something that doesn't necessarily have that component.
So why exactly is different?
What's different?
Yeah, what's the specific you would choose for that?
So you'd certainly have a safety plan, and environmental safety planning would be a big part of that. And we'll talk a little bit about what safety planning looks like. So for kids, creating a safe environment actually predicts risk significantly. And so, right, if you are cutting yourself and you're having a lot of things like accessible to cut yourself, one of the ways that I can reduce that as a parent or a caregiver is to remove access to all of those items. And we can talk, usually people say, well, if you're kind of convinced to do that, then you're going to try and find something to do it. The goal of safe environment planning actually is to make it hard. It's not to eliminate any choice in the situation and that you could find something. It's to reduce the likelihood that you're going to find it quickly and increase the likelihood that I'm going to find you, I'm going to notice that something's wrong, and I'm going to ask the question. Yeah. But I wouldn't necessarily focus on something like a safety plan if there wasn't some kind of suicidal ideation or cutting or something like that. That wouldn't be a part of every case of depression if that's not thoughts that kids are having. It's something that would be monitored though at every session. Sure.
Just out of curiosity, listening to you, okay, let's say the parent sees the problem, but the child doesn't, like the child's not cooperative.
Yeah,
Or,
that happens.
so how do you break through to have the child realize that we are all trying to help you?
Yeah. I think part of it is also...
Could they fight against the parents? Like, I don't want to do that.
Sure, right, that happens. I don't know that a lot of kids are super excited. A lot of depressed teenagers are super excited to come and see me, particularly not at 8 o'clock, right? That's no teenager's favorite time, by the way. I like that time, but not everybody else necessarily. I think part of it is also understanding the perspective. I think it makes sense to me sometimes where you kind of get into conflict about these symptoms, that kids kind of look really sad, they're hard to motivate, right? Their grades look poor, they're not necessarily helping out around the house. They're kind of tough kids when they're depressed, right? They're not easy, so it creates a lot of conflict. So coming to therapy is just another thing that you're asking me to do that I don't necessarily want to do. I also think that we assume sometimes that we understand what their perspective is, or we want to problem solve. And I'm saying this as a parent, right, as much as a provider. I actually resist that urge in both of those situations. But I think we want to solve problems. Like when kids were younger and you scrape your knee, we want to find a quick solution. If we can see tons of successes, if I can see that you're academically successful, that you have tons of friends, and that you're a really good soccer player, I see a lot of successes for you. But that doesn't necessarily mean that you see those successes for yourself. And so I think really helping to validate the teenager's experience is really important. So helping them to give a voice to kind of their symptoms and their side of the story, and kind of what are they thinking in that situation, or perhaps what parents are doing unwittingly to create some of that stress, right? If they ask me to do this, they don't understand, right, that I'm not friends with that person anymore, that this person was mean to me last week and I don't want to be their friend anymore. So really, I think helping to bridge that communication gap. That's why I say that parents should really be involved in a part of every session, because if they're just sharing that information with a therapist, and again, not that that's a bad thing to do, but I think it increases the amount of barriers that you have for parents to use those skills and to feel successful with the situation that you're talking about. So what do I do when they're not agreeing to come tomorrow or something like that? We all need to be on the same page about what depression is and kind of what we're going to do to treat it. Yeah, it's a great question. Other questions? Sure.
Yeah, so you mentioned some things like you wasted something, they know way back, and there may be a reason that they didn't way back. But what if that they didn't like you? And I don't want to use a friend, but let's say you have you're depressed because of a medical condition, and it's an actual thing.
Sure.
It's not a misconception of what the actual thing is, but this is my condition, so I actually have this, and it's not a way when somebody's not waiting back or
Sure, there are valid negative thoughts that kids have. I think that's part of actually this validation, right? That there are some situations where kids are being mean on purpose. That happens, right? So it's not nice, and we don't necessarily like to think about that, but it's true, right? That kids are mean on purpose sometimes. And I think if you're a child who has had that experience for a variety of reasons, then it's hard to be looking for those alternatives. I think my goal in that situation is I would say that that's a valid thought in some situations, right? So there probably are some people who are doing that to be mean and to have kind of a, ulterior motive, like a malicious motive in that situation. But there are probably other people who aren't, right? So because we're kind of so focused on a couple of people, right, who might be doing that to be mean or to be like a bully or something like that, we're missing the opportunities for a lot of other kids, right, who may be trying to kind of sit with you at lunch or those types of things. So our goal is to think about it. It's not very likely. Oftentimes in depression we call it all or none thinking. It's either 100% happening or it's 0% happening. And that's not very likely. It's just not, right? So there's probably 2 or 3 times during the day that something goes goes different and is more positive. And so helping to kind of train you to start thinking about those things before, especially if you have had a lot of those negative experiences, it makes it harder to kind of find some of those positives or successes at the beginning. But there is validity for those thoughts, right? It's not that actually all kids are kind of misconstruing the facts or like misrepresenting it. There is truth to a lot of those situations, for sure. Yeah, that's a good point. Other thoughts, questions? Those were good ones. Yeah. All right, so we're going to switch to kind of suicide prevention and think about that. I'm highlighting again the website for the American Foundation for Suicide Prevention. It's an amazing organization that does a lot of advocacy for suicide prevention, adults down to children. And they have a lot of tools and resources on the website that would be really easy to use and kind of pull down to think about it. They do a great job with this. So how we talk about suicide matters. So I put this up here because I think it's a really nice opportunity, even though we don't necessarily think about these kind of language terms for children quite as much. We really want to change the way that we talk about suicide. So we want to avoid saying committed suicide. So that's what most people say, right? Still, right now, I think we're making strides to kind of prevent that. But what does that kind of give the connotation of? Like committed kind of means what?
Focused plan?
Yeah, purpose, a plan. It also means kind of like we're doing something that's kind of a crime, right? That you might be put in prison for, or that you might be put in a mental institution for, or something like that. So I think it's a holdover of kind of those older ways that we thought about it, right? That it was a willful act that somebody was making that was kind of criminal perhaps in nature and kind of giving that connotation. But we know that that's not the case. So what we want to say instead, and you can actually see this trend if you look at actually media coverage of suicides, you'll see that they actually now list die by suicide, or ended their life, or killed themselves versus committed suicide. There's a whole set of guidelines that have come out in recent years about how the media should respond to these situations to decrease what we call suicide contagion. So just the language that you're using can make a big difference in how many other people start to kind of think about this same behavior. Failed or successful attempt, not the language that we like to use, so it's a suicide attempt or death by suicide. A few other key terms, just to kind of orient you to what are the different things out there that kids might be thinking or that we might be assessing. Suicidal ideation. So ideation is a thought of engaging in some kind of suicidal behavior. It's a thought only, right? It doesn't necessarily mean that there's kind of intent to complete that act or that there's a plan to do that. But it's important to take note of. Suicidal behaviors. So anything that would be related to suicide. So making acts to try and do that, that could be giving away your belongings, like those types of things that are kind of preparatory acts for completing suicide, as well as a suicide attempt or a death. Non-suicidal self-injury, we talked about that one because you mentioned cutting. So non-suicidal self-injury means that I'm hurting myself, but I don't have intent to kill myself in that situation. So not all cutting relates to suicidal ideation. It could be for a lot of other reasons. Again, it concerns me for a variety of reasons, right? It obviously can be related to this, but it's important not to assume that cutting or self-injury is with the goal of trying to kill yourself. A suicide attempt, so a non-fatal, self-directed, potentially injurious behavior. That sounds fancy, right? So something that you're doing to injure yourself where it could result in your death. It's really important to think about this one because oftentimes when I'm doing these assessments, I do a lot of like risk assessment and work in one of our training clinics. And I think it's really important to think about what the child thought in that situation, particularly younger kids. Don't have a lot of complexity about what actually might result in their death, but their goal was to die in that situation, right? So if I wanted to try and hold my breath until I couldn't breathe anymore, obviously that's less lethal because it's actually really hard to do that, thankfully. You can't do that for very long. Your body kind of like takes over that job for you. But if the child's goal was to try and hurt themselves, and it's really important to think about some of those things as an attempt. If I took a couple of pills, but not enough that would create my death, it's important to know that that attempt and those 2 pills were because I was trying to die, so that we're really kind of making good decisions about what we're kind of doing in terms of treatment, right? Just because it wasn't lethal doesn't mean that that wasn't the goal of the behavior. And that's pretty common when we assess kind of history of those behaviors, that children would have had one of these attempts. And then suicide obviously is a death that's caused by self-directed behavior. So what do we know? We know that there are risk factors, right? So environmental factors, historical factors, and health factors all play a part in suicidal risk. So historical factors are things that you can't necessarily change, right? So there are things that happen to you, there are things that your family went through, things that happened in your history that you can't necessarily change, right? So having a parent who completed suicide increases the likelihood that any individual would complete suicide. It doesn't make it a guarantee, right? It increases your risk. It's one of those things that we think about and assess, though, because it's an important historical risk factor for us to understand that current child or family. Being a victim of abuse is a historical factor, right? That could be kind of current and environmental, but that could be something that happened in your history. And we're learning more probably about adults with these behaviors as we learn about kids as well, because we're more comfortable trying to talk about it. It's actually really hard to learn a lot about current suicidal behavior. It's a really hard study to get somebody to approve, to be honest, right? We want to ask you to track that behavior, and we want to be thinking about that. What are you going to do? Is what somebody's going to ask every single time. So they're all a little bit conflicted, because you obviously have to work to change those behaviors, right, as you're assessing them. So those are some examples of historical factors. Health factors, so we know that a change in health, so a recent diagnosis of a medical condition, having a traumatic brain injury that kind of just occurred, there are things that happen that we know change kind of the context of the brain, or change kind of the trajectory about how people are thinking about life. And so those are a couple examples of health factors that could be pretty important. Environmental factors, so thinking about, right, changes in what we call kind of dynamic stressors. So depression, like having the start of depression, having a lot of changes, loss of friends, loss of relationships, parental divorce, like changes, those types of things. Again, no one of those things create kind of depression, but they're all environmental factors that we want to think about whether that's created a change in behavior leading to kind of the presentation that you're seeing. Any thoughts about that or questions? A couple?
How much does heredity factor in?
Yeah, so it's a good question. If we think about kind of the heritability of depression and anxiety kind of in general, they're not things that we have like a very specific marker for where we can say, if you have a parent who has depression, that increases your risk by this much. I was reading some information last night to prepare for this, and I looked for a statistic like this. So the one that I found at the CDC was that it would increase your likelihood by about 10 to 20% of having depression. But it doesn't necessarily mean, right, severe depression or those types of things. But 10 to 20% is also not most of the time. It's not if you have a parent who has depression that you're very likely to get that yourself. Mental health is a little harder to track than things like kind of cancer risk and those types of things. So what we know the most about from a biological perspective is probably schizophrenia and bipolar disorder. And I'll just mention what the statistics are for those, because I think it's helpful to kind of think about the context. So everybody, like all of us in the room, our rate of having schizophrenia or bipolar disorder is 1 in 100. That's just kind of your overall base rate as a general person in the population. So it's not very likely that anybody's going to develop those conditions. If you had a parent, a first-degree relative, who had one of those conditions, you oftentimes hear that that risk is doubled. But that means it's doubled to 2 in 100. So it's still not very likely that you would have that condition kind of expressed. And I think that's helpful to think about, because there's a lot of fear that's kind of out there related to those things. Because this happened, then it's very likely that that's going to happen to my child as well. It's just not something that we know that specific trajectory. We also know a lot more now than we did years ago about how to help kids and teenagers, right? So kids and teenagers until about 1980 were kind of largely neglected by mental health. It's true, right? So, sorry, it's a sad fact, right? I'm happy, right, that I'm a psychologist now versus like, in the 1970s. Because we just know so much more about how to be helpful. There were only 8 original childhood diagnoses in the first kind of mental health diagnostic manual that came out in the 50s. That only grew to like 10 in the 60s. But in 1980, that grew to about 100, because we knew that there were learning disabilities, that there were ADHD, that we knew so much more in that time period, because we were starting to pay attention to how can we prevent this and what can we do to kind of be helpful to create different outcomes for children. Yeah, sure, absolutely.
How do you kind of weed out or decipher the difference between true irritability and like ADHD medication crashes. So
Yeah, so
the
timing.
irritability that comes in the evening when your mental organization is
Sure.
done, you're smoked for the day, and
Yep.
you've crashed.
And all of us, to be honest, right? I mean, that's one of the reasons that actually bedtime routines and like sleep behavior is so hard to change, because all of us are really tired. By the time it's 9 o'clock, right, if kids kind of crawl into your bed because like they're used to doing that, and it's like, oh, we're just exhausted, right, by the end of the day. So I think the end of the day does that to a lot of people. I think timing is my short answer to that question, right? So there should be a change, and it's predictable by time, right? So if you see that type of behavior at that time of day, but you don't necessarily see it other times a day, that might indicate to me something like that. If you also experienced a medication change or like a dosage change or something like that that created that change in behavior, or a switch of a different medication, those are things that I would ask to try and see, is that a pattern that we can determine? If not, we don't know that right away. We can track really good data, right? So you could track kind of mood and what it looks like in the morning versus what it looks like in the afternoon or evening, and then kind of getting data from school. What does that look like all day? And that would probably add weight to it being a change in medication versus it being kind of related to depression. Yeah, great question. Other questions? Or thoughts about this? And risk factors?
What I was trying to allude to, I think, was this health factor, not necessarily the person not weighted,
Yeah.
but if there's a health condition that is getting the person down and they're not excited about, which is sort of, how do you deal with that?
Sure. And sometimes, again, depending on the medical condition and depending on what that trajectory is, there's kind of a derivation of CBT that you would do that's called ACT, like acceptance and commitment treatment, so that you can kind of accept certain parts of that disability that might be unchanging or that might be challenges, but then kind of commit to changing that. So it works on some of those action-oriented strategies, but kind of the framework of it and the education behind it is a little bit different, right? Because you have to kind of accept what are some of the limitations that are going to be ongoing versus feeling like you're going to be able to actively change all of those things. And so that's probably a framework that you would use a little bit more in kind of a medical context versus a non-medical context for depression. Yeah, good question. Other questions? All right, a key risk factor for suicide is having a mental health condition, especially when it's undetected. And so it's one of the reasons that, I'm excited that Pilot wanted to have presentations like this, because oftentimes people actually don't like presenting this topic and or like kind of hosting this topic, because it feels like it's really tough information. This is heavy information, right? It causes you to reflect on a lot of different things. But again, the hope is that if we understand these symptoms, that we're not going to be kind of missing some of those undetected cases, and that you're going to feel more empowered to be able to change it. But we know that that's a really big risk factor. If that goes on, if those symptoms that we were talking about in the beginning go on for weeks or months or years, it's going to be really hard to change. And it's also going to increase the likelihood that you feel more and more hopeless as time goes on. So suicide risk factors versus warning signs. This distinction is really important. So risk factors kind of endure over some period of time. So a risk factor like depression and the symptoms of depression might kind of go on for a longer period of time. While warning signs would signal more immediate risk. And so these are very specific signs and symptoms and behaviors that if you're seeing these, we would be much more concerned that somebody is having suicidal thoughts and or like planning to take action in the more immediate future. So it's really important to understand some of those. So what are kids saying? If people talk about killing themselves or just like, I should just kill myself. Kids actually say that a lot more these days than they used to. I blame the media a little bit for that, for a variety of different reasons, right? I will not share my thoughts about 13 Reasons Why, but I don't love it for a variety of reasons. But talking about kind of killing themselves and having that be a normal thing that kids say when they're frustrated happens so much more now than it used to. But again, we always take that seriously. I'm not going to assume that that means that you're not having that thought. Having no reason to live, so not really being able to think of any reasons that they would want to be here or that you would want to be alive anymore. Feeling burdensome, so like I don't want to bother people by talking about that. I don't want to ask my teacher for another paper because she's going to be annoyed with me. Feeling like you're burdensome is one of the factors that's actually emerging in more recent research to be a big predictor because you don't feel like you can actually ask for help. So if you feel like you're a burden to people, you're pretty unlikely to then use resources in that situation to kind of change what you're thinking and feeling. So there's more attention kind of being placed on sorting that out a little bit. Feeling trapped so that you don't have any options and you can't think of other solutions about how to get out of the current situation is something that we know is a warning sign. And then feeling just a lot of pain, right? Feeling like they're stressed, struggling, or in kind of an unbearable amount of like pain, like day to day. That could be physical pain, that could be psychological pain, and they're talking about those things. So behavioral signs, these are things that you would just see that people are doing and wouldn't depend on them saying it to you. Increasing or starting use of kind of drugs or alcohol is certainly a warning sign, right? Something's changed, something's different for a child who wasn't engaging in that behavior before. Looking for a way to end their life, so searching online, right? Looking at materials, looking at social media, right? Kind of blogs about like self-injury or suicide. Many of the phone calls that we kind of get and then work to kind of triage and link with resources are from parents actually calling in because they've noticed some of these patterns on their child's phone, right? If you're pulling your child's phone and you're looking at the history, and then they're worried about what do we do if we find some of those things. People would be worried about me, actually, probably if you looked at my phone now, because I was working on finishing this presentation while I was my daughter's volleyball practice yesterday, and so people would be pretty worried about me if you looked at that like 2-hour time period of search history. Acting recklessly, so not really like taking care for what they're doing, so a kid who might have not ever been a behavior problem at school and starts kind of acting out and saying things to teachers and those types of things, kind of taking a little risk and not really thinking about that as much anymore. Might mean that they're planning kind of not to be here. Withdrawing from activities, isolating from friends and family, so taking yourself out of a lot of situations. Sleeping changes, which we've talked about. Visiting and calling people to say goodbye happens pretty often. It's a very planful action, and so if that is something that like your child notices about a friend or right, you notice about your child, it's like one of those immediate behaviors that I'm really concerned about. Giving away things, right? I don't need this anymore, so I'm giving away a lot of stuff, or I'm going to go through my old toys and donate them for a kid who loves to hang on to stuff. It's like, what? Why would that be happening? And increased aggressive behavior. So you see a lot of that agitation, right? So its irritability is a little different than I think being agitated, where you're kind of moving toward like action, aggressive, like get out of my way, those types of things. And again, when you weren't seeing those signs and behaviors before that. Any questions about those? No? So what should you do if you notice some of these things? Talking to kids in private, right? So not necessarily asking the question in a group or a family situation or in a classroom. What you want to do is actually have them talk to you about how they're feeling. I want to ask not very many questions in that situation, and I want to hear a lot about what the other person is kind of feeling or what they're thinking in the situation. It doesn't actually take a lot if you're feeling that distress to open that line of conversation. You'd be surprised if you said, how are you feeling? I've noticed it seems like things are really tough lately. Can you tell me more about that? And sometimes kids will just talk for a long time with a pretty simple prompt. Expressing concern and care, that you're concerned about them and that you care about them, right? It's tough to see them kind of feeling sad. It's tough to see them, right, kind of changing who they're being friends with or, right, not feeling like they can be successful in that situation. We care about that. Asking directly about suicide. It's one of the myths that we talked about at the beginning, but I really think it's important to ask directly about, are you having thoughts about killing yourselves? Not hurting yourself, because that could actually be cutting or something else. If I'm really trying to assess whether somebody's having suicidal thinking, I want to know if they're having thoughts about killing themselves, very simply. And that's the question that I train all of our psychology residents and fellows to ask, is that I just want you to ask that question directly. And to couch that in, I ask all of the children and families that I work with questions about safety, because it's my most important job. So I really need to understand if you've ever had thoughts about killing yourself. It's a very simple, kind of lead in. I think we try to make it really complex sometimes and kind of build up to asking the perfect question. That's oftentimes what people ask me when I'm teaching about this. What's the right question to ask? There's not a right question, it's that you're asking the question, right? So however that's going to come out is going to display that you're caring, right, that you're listening, and that you want to know that information. And that's more important than asking the right question. Reassuring them that help is available. So that there are options, that there are things that we could do to be helpful that would prevent you from taking your life, because we would never want that to happen. So trust your gut, right? Assume that you're the only person who's going to reach out. So if you're noticing these things and you're thinking about it and something's not sitting well with you, I wouldn't assume that somebody else is going to ask that question. And oftentimes, again, teachers will have relationships and parents will have relationships with kids that are different than the other parent, right? That might notice some of these things a little bit more, right? Or you might have the chance to have a more personal relationship with a student because you see them in a smaller group. But trust that instinct. If you think that something's different, then ask the question. So talking saves lives. All you need is one person, right? The same thing is actually true for traumatic experiences. So research about the experience of trauma is also pretty clear that one person makes an enormous difference. That one person who's compassionate, who's caring, who talks about this and asks the questions can be really, really helpful. So you can access help 24/7. So this text line is what what I put on most safety plans because most kids text versus call these days. So essentially this text line is the same as the phone call. Right? They both go to the same area. And then if that call is like more serious for, let's say, it goes into a national distribution, they're going to send that to a state level representative so that you could have more immediate response if that's required. So that they want to assess that situation, let you know that somebody's there, and they respond immediately, right? Not like any delay, that they respond the second that they get a text or a phone call. They're going to reach a live person. All right, so wrap up. The top 5 things that I would hope that folks take away from the presentation tonight. So not assuming that somebody else has noticed or is going to ask. Not making that assumption and just kind of leaning into asking the question. Asking directly about suicide, so not falling into one of those myths. Have you had thoughts about killing yourself? Is that something that you've ever thought about? Both of those questions are really important, I think. Pay attention for changes in mood and behavior. Parents are always the experts of their children. You're going to know when something's different, and when something's different for more than a day or a week. So pay attention to that and trust that. Kids will talk about their feelings and thoughts, and pretty easily, right, based on a couple of prompts or a few questions, because most people want to actually share this information and feel less burdensome, that they would like to feel better about these thoughts. Treatment's effective, and parents are a really important part of the process. So parents should be integrally involved in treatment and making treatment decisions for their child. So feel empowered to do that. That's it. Other thoughts, questions?
Well, I have so many questions, so
Great.
Where to begin?
Right, well, we have a smaller audience, right? So people will probably appreciate that.
Because I feel like I didn't really understand this at all until this presentation. So my son's upper school night, I asked, it was an adult parents panel, and we were able to ask the counselors what's their number one concern for the upper school kids. And they said the number one thing that they're most concerned about for the upper school is anxiety. That the children are putting so much pressure on themselves in the upper school environment to get good grades, to get, so I was really sort of thinking, as a parent, I have to watch the pressure that's being applied, but I'm not sure, from what you presented, I'm not sure that if it's not a combination of a lot of factors together. So maybe you could help me understand, what is the normal teenage wave process through the moods combined with school pressure? Because I understand intellectually what you're saying, but I feel like I'm just entering the teen years, and it's gonna be fluid.
Sure. And again, that's true, right? So, hormones do, change kind of how you're feeling in different situations, those types of things. What we know is they don't predict changes in behaviors that go on for this long, right? So let's say, even if that's related to, your kind of menstrual cycle or something like that, if we're thinking about girls specifically, those symptoms would be different, they wouldn't maintain for, 2 weeks, 4 weeks, 6 weeks. You would see change if that was one of the primary factors that was kind of leading to that. So that's kind of one of the biological factors. I do think it's one of those things that causes us to probably not pay attention to some of these signs because we think that it's just kind of typical.
Right.
And so that's why I think about what's the typical mood versus what's more. And it's like these symptoms you're seeing most of the day, every day for about 2 weeks. That would say to me that that's not related to something that's probably typical. And I would give a call or kind of get that checked out. Most people start with their pediatrician, actually, for most of these things, not necessarily a mental health professional. And a lot of education is being done for pediatricians to help them be effective, right? To screen for depression. There are a lot of very quick, easy tools that pediatricians should use that we want them using to screen for this at adolescent visits. They're starting to do that more and more.
And so how do you then deal with school-related anxiety? Like, I'm growing up and I'm also dealing with the pressure that's being applied. Like,
Sure. Well, part of that's also, though, the internal part of what are kids kind of setting as expectations for themselves, right? Because oftentimes I think that's part of the conversation that I'll have a lot in treatment is that parents aren't necessarily saying you have to get straight A's or like A's and B's. It's like we want you to do your best. But if the kid thinks that their best is a 95, that's hard, right? I mean, inherently you're setting yourself up for an expectation that isn't realistic. So you're going to create the situation where you're disappointed a lot. So understanding what they view as successful is always what I want to know, right? So, and that looks actually different for every single person. Every single person I ask that question to says something a little bit different, like it's A's, or it's not a C, or it's that I have to have a 98. It's like, ooh, that's tough, right? Has it ever happened? And again, as you get older, school gets harder. So it relies more on studying and, right, those other types of things that are different than what you have to rely on and skills that you rely on as a younger child. So I think part of it is also kind of the organizational challenges and the study techniques and those other things that are probably, again, a lot more common in an upper school situation than I'm thinking about in a middle or kind of a lower school, that my expectation for that is really different. And sometimes kids get really stressed if they're not successful at a lot of those things. Does that make sense?
yeah.
But kind of understanding their perspective is really important, right? If it's not pressure that teachers are kind of putting on you or that parents are putting on you, it's like, we want you to be happy, we want you to be healthy, but, you know, what's your expectation for yourself? And like, what does that mean? It's like, well, I want to get into this college or I want to do this. It's like, ooh, that's tough, right? It helps me to have a different context for how to think about some of those, right, symptoms. Yeah, absolutely. Good question. Anything else? Sure.
Whenever I schedule, someone to talk with my son or have a session or whatever, it always ends up he doesn't want to go after a while, and it's like, do you force him to go or do you just let him not go,
Sure. So first, I'm sorry to hear that, right? So I mean, what we know, unfortunately, about mental health treatment is actually that the average duration of care is one session. Truly, right? As a professional, that's sad for me, right? I'm saying it because I think it's important that we work on actually engagement. That's why I talked about CBT. I could have very easily not talked about treatment at all tonight, and we could have spent time thinking about other things. But I think it's a really important part of advancing the conversation and figuring out what are the signs and symptoms, when is this something that's not going to go away on its own, and to help us kind of navigate those situations that come up as parents. Oftentimes what I'll say, actually, I usually schedule sessions in a block. This is just my personal kind of take on practice, is that I'll schedule 4 to 6 sessions and say, hey, let's see what we can kind of work on and see how you feel in about 4 to 6 sessions. And if it's not working, and asking for feedback each session is really important in being able to do that. Because again, I might have done something unintentionally, or a parent might have done something the kid really didn't like. And if I'm not asking for that, I'm not going to know, how to kind of improve. So feedback about that is really important. But we know that that initial engagement and how people feel in that initial kind of encounter and interaction is really important and predicts returning to treatment. There are things that we could do, actually a number of studies that say there are things that you could do in the first 20 minutes of a session that would help you predict kind of completion of treatment. So asking open-ended questions versus closed questions, like things that you would do to kind of help engage kids a little bit more. But it's actually really hard to talk about tough things. So sometimes I actually don't start about talking about things that are tough, right? Tell me the things that you feel like are awesome about your child, right? Because every child has those things. And if we're always talking about the things that are tough, none of us really want to talk about that, right? I don't really want to talk about the things that I'm the worst at, right? It's not super fun for me and enjoyable. So I think thinking about that and kind of incorporating that, or making some of those suggestions, if you know that to be the case about your child, helping the provider kind of understand, here's something that I think would be really helpful. All kids respond to some of those sessions a little bit differently. But again, making sure that you're getting feedback is really the only way to figure out what you could be doing a little bit differently in that situation. I usually ask people, what didn't I do today, right, that would have been helpful? Right, what I miss, right? I must have missed something, right? I'm not perfect, I don't have a magic wand, and I'm not a mind reader. So there's probably something that like I could do a little bit differently that would help, would improve. I think it's a great question. And I think, again, you probably make that decision based on whether you also feel like you're getting kind of the answers to questions that you need to feel like it's effective treatment, right? If you feel like this wasn't a good interaction and that I didn't feel, right, very comfortable either, then you should really trust your gut about that, right? I would hate for that to predict, though, not seeking treatment overall, because there are a lot of people who might be a really good fit that are out there and are doing really effective treatment.
It's the fit.
It's the fit. Yeah, we know that like people look at completion of evidence-based treatment and this treatment versus that treatment, and there's something to be said for like the therapist fit. It's kind of this intangible variable that predicts whether people complete treatment. And it's a really important thing to think about. Because everybody's not a good fit, right? Their style is a little bit different. Yeah, that's a great question. Sure.
I know you mentioned that, kids are often willing to talk and there's no perfect question, but do you have any advice on sort of breaking through barriers if they do just sort of throw up walls and, everything's fine, that kind
Yeah.
follow-up questions or anything like that?
Yeah, so I think I oftentimes encourage families to set kind of like a daily conversation time and a check-in time. And that looks a little different for every child, but just asking questions about the day in like a rating scale, right? So if you could rate the day on a scale of 1 to 10, 10's the best day ever and 1's the worst day ever, what would you give today? What do you think the week has been like for you? Sometimes I'll do a lot of scaling questions like that. My sixth grader would tell you, oh my gosh, you're going to ask me a scaling question. Right? It's true, right? I love scaling questions. It's helping me know how big is the problem or how small is the problem. But you can tell a lot by asking questions in kind of a creative way like that versus like, what's going on. I also think sometimes we ask what's wrong because we notice that something's different. And sometimes it's hard, again, for the reasons that we talked about, it's kind of hard to sometimes engage in treatment. It's really tough to talk about the things that are not going well sometimes, particularly if you haven't talked about them a lot or you're not a kid who's a big communicator. So I think helping to kind of get a sense for, here are the things that we kind of noticed. Would you agree that those are things that you're kind of feeling, or where am I kind of getting that wrong, right? Am I wrong about something? So then they might kind of start to pick that apart. Teenagers especially love to argue with you and debate that. Right? They want to argue, did I get this wrong? So what I think is that in this situation, you're probably, right, not wanting to do this at all. Is that right? And then they're like, well, no, that's not how I feel about that. So you could engage them actually to kind of argue with you a little bit about it, and then you can learn some good information through that. Scaling questions are kind of my go-to though, right? Even if it's like a really good day, a pretty good day, or a terrible day. Younger kids, right, I'll ask those types of questions because the numbers don't mean as much, but they can kind of give you a sense for like, what are those days? And if I start to ask that question over a day or a week and I just force you to answer that one question, I'm going to know if your mood's usually a 2 out of 10. And if it's always a 2 out of 10, then I'm going to be more concerned about that than if there's kind of a range that we see and like that 2 is just kind of a bad day. It's an outlier. Yeah, great question. Yeah, for sure.
I was going to say, I think along those lines it's so important to consider timing, because I think, asking that question when they're just coming out of school, you may get a very different question, a very different answer rather, than when things are calmer, and again, it's not just them. I know we often play a game of rosebud and thorn, and so a rose is something great that happened that day.
Yeah.
Thorn is something that, wasn't so great. And bud is something you're looking forward to.
Right.
And everyone goes around the table rather than just to feel like all eyes on that child. And I think it's a great time for parents to model that idea of, some days are better than others, and here's how I handled when this happened.
Right. And everybody needs help too. I think that's an awesome point, right? So sometimes if you are trying to encourage the child to kind of share about their feelings, I'll encourage parents to actually model talking about things that were tough or things that you needed help with. Right? All of us need help with something each day, right? In a work situation or a home situation, all of us need help doing something, but we don't really think about, right, sharing that information. Exactly like you said, like what are the roses versus what are the thorns? Immediately, like we think about problem solving. We're just geared to think about problem solving as like parents, as teachers, like we want to think about what happened and what do we do to change it. And I get it, right? It's efficient. It's effective, but it kind of misses some of that if there's not an easy solution or there's not a strategy that you're going to come up with right away. And it's just like, well, it's just a terrible day, right? I'm really bad at everything. It's like, well, what do you do with that, right? You can't come up with like an immediate strategy.
Listen.
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 Yep, listening is really important. Yeah, but I think starting with one of those simple questions or activities like that will oftentimes kind of gain you a lot more conversation overall. And if kids are not necessarily talkers, the other thing that I really like a lot is actually you can buy or look up on your phone conversation starters that are funny things that you could ask for like families. You know, what's your like favorite, vacation? What country do you hope to visit someday? Those types of things that could get everybody kind of talking about something a little bit more generally versus it being specifically about what was wrong or what kind of went well in the day. So just opening kind of those lines of communication more broadly. Yeah, great point. Thank you.
You mentioned that depression and anxiety are kind of close cousins.
They are.
So if maybe more of the issue is anxiety, is that treated similarly? Do you use cognitive behavioral therapy?
Yes.
With that as well?
Yep, you do. So cognitive behavioral therapy is super effective for most of the disorders that we're going to identify in children. So the way to kind of separate those sometimes is, it's a fancy kind of word for, like me as a professional, content specificity. That sounds really fun, right? It sounds like, wow, what's that? It really means what's the nature of what kids are saying and what are they thinking that predicts whether this is anxious or whether this is sad. So depression is really characterized by kind of negative thoughts about yourself, about the world, about others, right? You kind of have those negative thoughts about what people are thinking about you, your negative beliefs about the world. Whereas anxiety is more like overestimating danger and the likelihood that something negative is going to happen. And so if you listen to kind of what questions kids are asked or what they say, it's like, oh, I got a terrible grade on the test, I'm probably going to do terrible for the rest of my life. It's like, I'd want to learn a little bit more about that, right? That could be depressed. It could be that, you're worried about test taking. So paying attention to what the content of their thoughts are can help you separate whether something's anxious versus whether it's more related to depression. And again, they can lead to each other on a continuum, right? So anxiety can lead to depression if it goes on for a longer period of time. And if I think about the social example, right, you take yourself out of social situations, then you are probably isolating yourself, right? You probably don't have as many friends as you did before. Is that because people don't like you? Maybe not. But you've progressively kind of taken yourself out of the situation because you've been pretty nervous about it for a while. And so it's kind of an unintended consequence to that change in behavior that you had. Yeah, absolutely.
I'm not sure how to phrase this, but how to ask this question. But I have a 5-year-old who you mentioned earlier about negative thoughts of themselves or inappropriate level of guilt, and to be so hard on themselves. And I know they're 5. Is that something I should be concerned as they get older? Because I feel like they're really young right now.
Sure.
And part of me is also where is this coming from?
Yeah.
Especially
I think it
with
sounds more
accidents.
puzzling, right? When younger kids kind of say it, we feel a little bit more puzzled by, we don't have a lot of expectations for you. I'm 5, right? What are you not doing well, right? I'm a little puzzled about that. I think it's a really good point. So one of my very favorite books, if I could recommend that parents would read probably one book, I've read this book 3 times because I like it and I read it more throughout my career and pick up different things related to it, but it's written for parents. By a professor from the University of Pennsylvania, Martin Seligman is his name. Most people would associate him as the founder of kind of positive psychology, so mostly aimed at adults, but he's got this awesome book called The Optimistic Child. So his idea behind that is to kind of think about your glasses half empty kind of kiddo, and how would you work to kind of coach being glasses half full? How can you change that kind of mindset and perspective by thinking about these activities? A couple of his activities are kind of starting conversations with 3 daily successes or 3 things that you're feeling grateful for, and that you do that every day, starting at a young age, so that you're kind of gearing them to think about the positive first versus the negative. And that's a strategy I oftentimes use for younger kids in treatment, right? So parents have to generate a lot of those successes, and sometimes it's hard for kids to do that if they are feeling pretty anxious or sad, but you see over 4 to 6 weeks that kids start to do that on their own because they're seeing that other people are noticing that about themselves. So what they're not noticing, for younger kids you can get them to pick up on, but it's the case for teenagers too. They don't like it as much, right, as younger kids do, and they get all smiley and excited, and you can put on a little post-it and they feel super excited. Teenagers don't love that as much, but they like the activity too. But the optimistic child is a great one. So his idea behind this philosophy was that if you could, he attended a talk by Jonas Salk, right, who developed the polio vaccine, and he thought, wouldn't it be great if we developed a vaccine or some kind of, treatment that would help to prevent depression? And so that's what all of this kind of work has been aimed at. So they're mostly school-based programs that they tested actually in the Bucks County school system, and it talks about what strategies that they use to kind of prevent depression. for general kind of populations, but also kids who would be more at risk with some of these historical factors or those types of things. It's an awesome read though. It's very user-friendly and has a lot of like kind of fun tips that you could incorporate pretty easily. Great question. And you asked it well, right? You were worried about that one. Yeah, it worked out. Other thoughts, questions? Sure.
I'm going to be a downer, okay, the Debbie Downer. Okay, we're talking about the suicide and all, and I'm sorry, it's so hard to conceive this whole thing, but these shootings that go on, and I know most of these kids, I assume, are, the end result is suicide. So how do you, first of all, how do you know this is going on, and where is their thinking coming from?
So it's really complex to sort through those types of situations. As like school shootings unfortunately have been more prevalent,
exactly.
They're starting to kind of put resources into trying to understand and analyze that a little bit better, but we're actually not very good at predicting what the type is, like what are factors that would relate to that and where it wouldn't relate to that, right? We're not very good at predicting that, but it's also because thankfully we don't actually have a lot of data, right? So we have more data now, but you actually have to have a bigger set of those types of situations to kind of isolate some of those triggers. But we don't know for sure that there are factors that would lead you to be kind of a school shooter, let's say, versus not. And that there's not an opportunity necessarily to intervene. So I'm not aware of at least any kind of very predictive factors that would say these 2 or 3 things are what would predict that behavior versus not. I think it's a really complicated question. Yeah, it's sad, right? It's tough to think about.
It's heartbreaking. And
it's hard work to do, right? So there are not a lot of people who are able to kind of think about that work. It'd be really hard for me to do that type of research, right?
Plus,
and think about that.
Plus, if they have the suicide, you can't talk to the child to see where they're thinking.
Yeah, it's all retrospective and kind of getting data from other people so that you don't necessarily know, what they were thinking in that situation. That's why you rely on all of those other sources of information that you read about, because you have to try to put together kind of a picture. They're borrowing from actually all of the FBI task force work on like serial killers and those types of things, right? There are other things that you can kind of do to think about that for adults, but we didn't really think about that classically for children. Yeah. Other thoughts, questions? Sure.
Is it ever been maybe observed or documented that sometimes children or teens can threaten suicide, but it's really about manipulation or to get what they want instead of actually being serious about it?
Sure. I am actually really happy that you asked that question. I feel a little remiss that I didn't include something about that, so thank you for asking that. My question to that, and I hear that come up pretty often, and I guess I think I'm not willing to take the risk, is my response to that. I'm just not. Right? So if it is manipulation and we have a safety plan and we talk about this and we focus on this so much in our sessions, if it really is related to kind of negative attention seeking or something else, we get teacher replacement behavior, and kids aren't going to want that type of focus for very long. Right? They don't want parents to be asking safety questions and checking to see if they've cut by looking at their arms. Like, it feels intrusive. And so if it's not necessarily related to that, and again, I'm not suggesting you do that to sort it out, but if it is related to that, then you've addressed it and you know that like this is not necessarily something that's going on, but the behavior changes. You also don't see that and you don't hear that thought kind of expressed as much anymore. Oftentimes actually for younger kids, it's like in a frustration kind of anger, right? When kids will say, like parents will say, oh yeah, I was really worried because the kid said like I'm just gonna, kill myself or I want to die. And it was related to when they were angry, right? So then really completing an assessment to see was it related to something else or not, but still not an appropriate way to seek support in that situation. So even in that situation, I would take it seriously and I would figure out what else I do to kind of shift that behavior, because it's not an appropriate way to kind of express frustration. Yeah, but my short answer to that question is I'm not willing to take the risk, because we're talking about whether your child's alive or not. And so I'd rather aim that they're serious in the short term until we prove that that's not the case. Yeah, good question. Thank you for asking that. Because it does hold a lot of power.
Yeah.
Right? I mean, that's what oftentimes people will say, right? That it creates a lot of power over what we do in the house and those types of things. And it's like, I totally get that. In the short term, let's get an evidence-based way that you deal with that. and then see if we can change it.
And you also listed a lot of other symptoms that seem to go along with it, so are those other symptoms present along
Right.
with the talk? Maybe
Right, it's where those frustration, kind of like, anger kind of, things that I'm just saying because I'm frustrated and not accompanied by other behavior or actions, that's what you're kind of looking for in a thorough assessment, yeah,
So,
absolutely.
so related to that, if you presented to that, you basically don't want to reinforce that?
I would always take it seriously.
No, yeah, I understand that, but I mean, if that's an effective strategy for that individual to gain whatever they want or whatever.
Yeah, right, to gain a resource, to gain attention, to gain a privilege or something, I would say we have to work to replace that and figure out another way for you to get that privilege, right? So if you don't have to do homework because you get really frustrated and you throw up your hands and say, I'm just gonna kill myself, then we have to figure out a different way for you to kind of deal with that, right? And I can reward that behavior and we can think about it separately and kind of coach that. But yeah, I wouldn't want to replace it with something else. Good questions. Other thoughts? You guys had a lot of awesome questions. Anything else? Yeah. All right, well, thank you guys. You were an awesome audience.